definitely excited about being invited to the Rethink Church Virtual Summit. And our topic today is health and addiction disparities in urban communities. And myself, my name is Pastor Kelcy G.L. Steele, and I'm the senior pastor of the Varick Memorial Church in Dixwell community of New Haven, Connecticut. And I have online today, I have Dr. Jordan, and I also have Sylvia Cooper, and we're going to allow them to introduce themselves and tell how they became involved in the work. And so we'll start now with Sylvia Cooper, and then we'll go to Dr. Jordan.
Hi, so as Pastor Steele indicated, my name is Sylvia Cooper. I'm a longtime resident of the city of New Haven. I've worked with single families and shelters and advocacy and education. And I'm a member of Varick for about 3 years. But in 2018, Pastor Steele asked me if I would be interested in doing some work with the Imani Breakthrough project. And so as a result, I went to attend some facilitator training at the PERCH program, which is Yale Program for Recovery and Community Health. And during that time, I got to know a lot more about individuals and families who are impacted by opioid addiction and mental health. And so that was my journey as I began over the last 2 years.
Thank you so much, Pastor and Sylvia. I am so glad to be here with all of you and very grateful that Varick has been invited to participate in the summit. My name is Dr. Ayana Jordan. I am an addiction psychiatrist. That means a doctor who specializes in helping people with drug and alcohol problems, from engaging in recovery all the way to making sure they're safe and taking their medications and staying alive, let's say if they're withdrawing from opioids like heroin and also alcohol. I did not initially train to do this work. I spent the first kind of 10 years of my career actually in infectious disease, so thinking about HIV, and went to medical school to get a medical degree, right, a doctor of medicine, and also a PhD, and spent a lot of time in the research lab looking at how diseases pass from one person to another. And at the time, I was working in the South Bronx in New York City, and I was assigned during one of my clinical rotations and taking care of people with mental illness, and I can tell you that changed my life. I had never, ever seen in the United States such poverty and people being treated so badly, not only by the medical community, so other doctors, but also by their families. And many of them were shunned, unfortunately, by the church. And so there was a misunderstanding, like people with mental illness and addiction are suffering. And that really touched my heart. And I think the Lord allowed me to have that experience to change gears, not to totally abandon the field of medicine, but show compassion and research for people who are often forgotten. And so with that experience, I changed courses and decided to do intensive study, which is how I got to Yale. I pursued training at Yale in 2011, so I've been here a long, long time, and then did more training, specialized training in addiction, and now work at the hospital and also at the Connecticut Mental Health Center. I'm so excited to partner with Varick and also Pastor Steele, because he really does set the mood and kind of context for making people feel safe to talk about addiction and get help, and realize that it's just as important as dealing with somebody that has high blood pressure or diabetes, that we need to deal with the addiction in our community. So I'm grateful to be here.
It's good to have both of you, and I'm the proud pastor of both of you guys. And I thank God that he has used you two to bring about this great vision for our community, because before arriving here 4 years ago, I never thought I would be participating in addiction ministry, health ministry. And so by coming here in Dixwell, we know is one of the poorest communities in New Haven. and the population, it's everywhere. Addiction is everywhere. And when I say everywhere, I mean everywhere. And so that was a part of the vision that the Lord gave me upon arriving, that Barrett will become a epic center of social ministries, ministering to the holistic person, not just spiritual, but mind, body, and whatever the situation is, that we will have a ministry in place to minister. And we thank God for you two for actually bringing that to pass. And I'm looking forward to the future of this movement and this ministry. And this year, we was able to go to Charlotte, North Carolina, and receive the 2020 Balm and Gilead Healthy Church Award. And I believe we have a video that we would like to show you.
Yes, Pastor, I'm going to share my screen so that we can show it at this time.
The Barrett A&E Zion Church is over 200 years old, and we are one of the most historical congregations in the city of New Haven. Our vision statement is to become a relational church doing relevant ministry by becoming warmer through fellowship, deeper through discipleship, stronger through worship, broader through ministry, larger through evangelism, and faithful through stewardship. The Barrett Memorial Church became involved with the Imani Breakthrough project when one of our members, Dr. Jordan, came into my office to share a vision that she received. And we talked about it, and we agreed that Barrett would be a satellite and a case study for her project. And from there, it just blew up. This program had been in existence since April 2018 until now, and we have served faithfully 175 people this year with 22 weeks of programming.
I've loved working with Imani. Imani means faith, and it's given me a lot of faith to do a lot of things I didn't think that I would be able to do, like breaking out into the community and put myself out there to be an advocate for others and helping out others where that strength was never even possible before. I didn't think.
Barrett Church is located in one of the poorest communities in the city of New Haven, Connecticut. We're constantly seeking better ways to provide our members and community with healthier choices through food. The food is provided at our soup kitchen once a week, and they receive organic fruits and vegetables while they're there. It is our hope, it is our thoughts that people can be healed through mind, body, and spirit.
Amen.
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 Amen. And so we know that Sylvia is on the front line, and she's our site coordinator and our supervisor. And so Sylvia, can you share what are some of the successes that you have seen working with Imani?
Well, Pastor, it's several successes because there's no one size fit all. Each individual has their own journey. And so when we first started the program in 2018, we had individuals from the ages of 18 to 72. And so we don't try to lump everybody in one category, although they struggle with the same kind of addiction. For example, we had a man in his 70s who'd been using for 50 years, and his goal was basically to learn how to read. He had housing, he was caring for his sister, and so his goal would not necessarily mean to go out and get a job and to, be an addiction, to use less because his addiction was real, but to learn how to read and to be able to spell his name. So that's a success. And then others have gone on to, because we work closely with clinicians and community service providers. And one of our roles is to get people housed, to get them in addiction, whether it's outpatient, inpatient. And so, again, I'd like to say that there's no one size fit all. Each person has their own journey, and the group is just so close knit. They find their voice within the group. We become one family. And the goal is for each person to identify their issues and then find that way that they can navigate to become a person in our society in their own lives again.
And of course, the programming is based upon the 8 dimensions of wellness. And so how is that working
Well, we talk about health, and I'll name them: health, wealth, emotional, spiritual, behavioral, intellectual, social, and financial. Now, I just said a lot. Those topics are introduced to the group, and then we, based on the curriculum, we create conversations, because it's one thing for, people use a lot of times money for their habits, and we give them a way to look at money in a different way, and social, emotional. Although the program is in a church setting, the physical space, we let people identify themselves for who they are, with God being in the center. We don't force people to say, you believe what we believe, but the greatest thing about God is his love. And so the topics help people. I mean, people didn't even think of themselves as health. When you go to the dentist, and that if he's gonna take your tooth out, he's gonna prescribe narcotics. And for you to be able to say to your physician, I have an addiction, or I have a problem, there are alternatives. So really, the subjects really help people see themselves as a person and identify with those subjects, and especially relationships around them and the relationship with themselves.
Amen. And just for the audience to know, the 8 dimensions of health is social, spiritual, financial, physical, emotional, occupational, environmental, and intellectual. And so those are the 8 dimensions of health that our program is built upon. And we also have 5 R's: responsibility, resources, relationships, roles, rights, and sense of belonging. And so it's a full curriculum. How many weeks?
22.
22.
22 weeks. And at the end of those 22 weeks, we have a amazing, wonderful, exciting graduation ceremony. And they're able to invite their families, and just to see the smile of each individual person as they feel a sense of accomplishment is amazing. And so what is the success rate? Like, can you give us some numbers? How many have went through the program?
Yeah. Go ahead, Sylvia. Mm-hmm.
Well, the funny thing about when we started, the goal was just to get 15 to 20 people enrolled. By the week 3, we have over enrolled in that, and certainly we had to increase our numbers by 40. So the greatest tool is we went out and we marketed the program, but the word of mouth, that's it. And the way where Varick is located, we're on the bus line, we're in the heart, of the city of poverty, and people started telling their folks, friends, and family members about it. So it's self-recruited at this point. Wow. Ayana?
Yeah, no, one of the things I want to say is first, just really honoring you, Sylvia, for all the work that you're doing. I love when Pastor said, really on the front lines, you are really the spirit and the center of Imani, and really the heart. You believed in it and the execution. And so we're so grateful, because I really think that the Lord is using you as a vessel to minister to people's lives and to provide purpose. So yes, it's important to go through the 8 dimensions of wellness and the 5 R's and sense of belonging for purpose and recovery. But I just want to publicly acknowledge kind of ministry being outlived through you, Sylvia, because we couldn't do this without you. So glory be to God, to you.
To God be the glory, yes.
So one of the things that, Pastor was talking about is outcomes. And it's important to know that Imani now is in 8 churches throughout the state of Connecticut, 4 Black churches and 4 Latinx churches. But Varick has really been the pinnacle and the leader of really showing the way in terms of what is possible for the growth of this program. And really thinking about Imani, Drs Bellamy and I just had a vision. And Pastor didn't even really know me. I came and he said, okay, we'll talk about it, and was so welcome to it, not really knowing all the details. But what is so exciting is that now, 2 years later, we're seeing people's lives being changed to the point where people who literally were in the throes of addiction, not knowing any support, not feeling like they had anywhere to turn, are part of the Imani family and feel directly connected to Barrick. So when we're thinking about outcomes, of course we want to decrease substance use, but we're also leading people to have a stronger relationship with God, but also with themselves in terms of I have value. So when we're dealing with a lot of people who are impoverished, like we talked about, people who are living in areas where they don't have access to food on a regular basis, they can't even read, Sylvia, like you were saying. A lot of people, even if they graduate from high school, they still struggle with literacy. They might not have relationships with other people that don't do drugs. They've been called crackheads and whores and everything but a child of God. To enter into Barrick and be model unconditional love, it's beyond just substance use. We're looking at changing people's lives and the quality of their lives. Another thing that I think is important about Imani that is so powerful, especially in the context of what's happening in our country now with anti-Black racism, is seeing the depth of despair that people experience when they are victims of racial bias. So when people don't have language to say, why is somebody following me around the store just because the color of my skin? Or why do people automatically think that I'm going to do something wrong just because of how I look? Or why is there more police in my neighborhood just because of the color of my skin? Imani allows a space where people are able to put those two things together, understanding that Black people in particular and people of color in particular have struggled in this country in a way that other people have not. And then that can also lead to cravings or triggers of wanting to use or even maintain recovery. So it's a special program because not only are we talking about the medical side, but we're also talking about, like Pastor said, the social, emotional, and spiritual side of addiction, right? All of the things that we know contribute to people using. So it's such a powerful program. And again, I just wanted to emphasize, yes, people are decreasing use, but more importantly, people are increasing their overall quality of life in all those domains. So talk about a testimony, that's so powerful. And I think because there is leadership from the pastor directly, that definitely translates into why it has been such a huge success at Barrick specifically, for sure.
But you guys touched on two important major things, how race and health correlates with one another. And I always say that we are suffering from two pandemics, not just a COVID-19 health pandemic, but also a racism pandemic. And that was one of the factors that pushed me to kind of lobby the city in order to declare racism a public health crisis.
Yes, yeah.
Because if you're Black in America, racism, it affects your entire life,
Right.
mind, body, and spirit. And we were successful in getting that passed, but we are sitting in anticipation to see what that's going to look like, how that's going to materialize, because they go hand in hand. And this COVID-19 pandemic has really shed light on some things, and this can kind of be a segue into you, Dr. Jordan, because we're going to be talking about health and addiction disparities in urban communities. This pandemic has really shed light on the disparities in our community. Not as if we didn't know that they were already there.
I said, we already knew it. the West of America had to wake up to it.
We knew it was there, but I think it shed light to a lot of other people.
Right, yeah.
Like, okay, we closing schools. Okay, so how are our children going to do distant learning if they don't have, number one, computers?
Exactly.
Yeah.
And so all of this has kind of brought some things to light, or has shown people things that we've already seen and already known. And so I'm going to, allow you to talk about health and addiction disparities in urban communities, because there are a lot of disparities, and 45 minutes is not enough time. And so I don't know where you would start. I don't know
yeah,
where.
Yeah.
So much.
Yeah, no, thank you, Pastor, for setting the stage. So I want to just really touch on a few key points. So if people kind of daze out and come back in, really just to understand some key points. The first thing is that racial and ethnic minority people, namely I'm going to be talking mostly about Black and Latinx people, those are people of Latin descent or African descent, are not to blame for healthcare disparities, okay? The color of your skin does not equal you being the cause of why your health is bad. There are conditions that are assigned to you because of your race that disproportionately affect people of African and Latinx descent due to racism. So I always say racism, not race, is the cause of healthcare disparities. That's the very first point. In a lot of even medical literature, people always say, Black people have a higher incidence of this. And I say, okay, but the question is, why do Black people have a higher incidence of this? And the answer is racism, not because Black people are doing things that they shouldn't do. Okay, so that has to really be an important point, because I think America has spent so much time blaming the victim without providing the cause of why we're in this situation. So that's number one. The second thing is that there is, and we all know this to be the case, but it's important to highlight, a deep mistrust of the traditional medical system that results in further worsening of healthcare disparities among Black and Latinx people. Again, not because Black and Latinx people are bad themselves, but because there is a history of medical systems mistreating them. And so because of those experiences, both past and present, that has contributed to people not being trusting of the system. So we have to understand that, because it's not that Black people and Latinx people just decided one day they don't want to take care of themselves. They are making an informed decision not to be hurt by a system that has historically either maltreated their family members or may have presently mistreated them. So that's a second point that is a big contributor to healthcare disparities. One, racism, not race. Two, mistrust of the traditional medical system based on historical and present atrocities. So that's another kind of point, if you don't listen to me at all, to understand one of the causes of healthcare disparities. A third and really big part of this whole pie of healthcare disparities is understanding an absence of culturally informed care. So what does that mean? That means that many of the treatments that we have for addiction are really any disease in this country. It could be asthma, breathing problems, it could be diabetes, insert any illness, even cancer. There has been an absence of people not from the majority culture, so people that are not white or who are not assigned to the race of white. They have been totally left out of what treatment looks like and what treatment feels like and what should be involved in care. So when we think about people of African and Latin descent being a very spiritual people, It's not uncommon for us, and this is based in the literature. This isn't, you don't have to take my word for it. There have been a lot of sociological and seminary research to really show that people of African and Latin descent are spiritual people who don't see treatment as being either or.
Right.
A medical model doesn't have to be divorced from a spiritual model. So when I say a lack of culturally informed care as leading to healthcare disparities, I'm saying that there aren't many treatment modalities in which people from racial and ethnic minority backgrounds feel like that they can bring their full selves to the treatment, feel like they can pray, feel like they can call on the ancestors to help, feel like that they can have elders lay hands on them. This is so important, but it has been deemed to be unacceptable in the majority white culture. And so again, the absence of even having people from those backgrounds involved in what care looks like, that can also lead to healthcare disparities. I always say, nothing for us without us. How can you have a whole treatment program and you didn't even ask me what's important? One of the things Sylvia said in the intro is so important. There is an elderly man in the program in his 70s that has had 50-year history of addiction. The traditional model of care might be you have to stop using substances. One of the things that we're able to center in Imani, that is our goal for you, but what is your goal for yourself? What does healing look like for you? The fact that we can even use the word healing is an example of culturally informed care. For this elderly man, more important than stopping the use of substances, even though that's a goal for us, was for him to have a purpose, to be able to say, I am a man, someone with value, someone who genuinely is a child of God. The world might not view me as such because they're killing people like me in the streets. They might not call me sir. People may deem I'm a dope fiend. But we're saying that you have value, even though the world has all these identities, and you are valuable enough to be able to make an informed decision about your treatment, which is to be able to read and write your name. So that's an example of how powerful treatment can be when you involve culture, i.e. the patient or the person who needs help in the care. Okay, so now I do want to transition with those three things in mind. Racism, not race, mistrust of the medical community, and lack of culturally informed care as all ways that contribute to healthcare disparities. All right, does that make sense? Now I want to transition in the next 10 minutes to really think about how the syndemic, like you said, Pastor, both the pandemic of coronavirus and also the pandemic of racism have come together at a syndemic, two pandemics at the same time to further exacerbate healthcare disparities.
Wow.
So now we have people who are already vulnerable to disease because their bodies are not in ideal condition to fight viruses, okay? Right. So when you have an addiction, you're not as healthy as someone who does not have an addiction, period. We know from the literature, people who smoke crack cocaine, who inject heroin, who smoke heroin, who inhale heroin, who smoke cannabis, who use alcohol. Over time, your body is not able to mount the defense needed to fight off viruses, such like the coronavirus, the novel coronavirus, which causes COVID-19. So I just want to put that into the atmosphere because people have to understand we're already dealing with people who have healthcare disparities because of those three things I told you about. So they're already vulnerable to this virus. Then on top of it, you have the virus. So these are the people that are at highest risk of getting infected with COVID. But then let's add on racism. So because of a system that has based on race that systematically disadvantages non-white folks, they are not treated in the same way for their addiction and the virus that they're highest risk. They don't have the same opportunities in the areas in which they live. We talked about Dixwell being where Berwick is located, one of the poorest neighborhoods in New Haven. So if you think about what resources are available in a poor area, they don't have access to clean air, places where they can walk to effectively physically distance from one another. I like to say physically distance instead of socially distance because I know more than ever we have got to stay socially connected while physically distancing. We are a communal people. So thinking about the totality of our spiritual and emotional health and our spiritual health, we gotta stay socially connected while physically distancing. Mm-hmm. But let's talk about how cruel racism is. How can we stay socially connected while physically distancing if we don't even have access to Wi-Fi? Wow. Because of racism.
Yeah.
Right? So we don't even have the necessary equipment in these poor communities that are largely made up of Black and Latinx people. So not only are we not physically able to keep ourselves apart, right? Which allows for more transmission of the virus. Many of us live in housing complex because we cannot afford to own our own homes like majority white populations. Again, not because we're lazy, not because we didn't work hard, but because there were historical racist programming in place called redlining that made it illegal to even get a loan in places where you were able to have nicer homes, be able to physical distance. So all of these things come together and create further vulnerability on top of a population. Remember I told you, already vulnerable because of the addiction, and then came COVID, and then because all of these racist practices that are in place because of housing and environment and poverty don't allow people to make choices to be able to keep themselves safe. So then this brings us to the point of, at the height of the epidemic, which is still occurring in certain states. So the occupant in the White House might make you think that the pandemic is over. But we have to understand, Black and Latinx people, but especially Black people, are still dying at disproportionate rates related to the pandemic. How is the media part of structural racism? Because the media is not covering the deaths of continued Black folks in the way in which they would have covered it if white people were dying at these rates. Wow. We heard about it in the beginning, but I'm here to tell you that even now, in certain states in this country, Black people are dying at 2 to 3 times the rate of other people. And so I always tell people, if you don't even have access to information, that's a way in which the general media can be racist, because people rely on the media to get access to information to keep themselves safe. But if the media won't even cover what is happening in racially and ethnic minority communities because they don't think the lives are worth it or it's not newsworthy, people might not even understand that they continue to be at higher risk. So that's why I feel so grateful for Barrick, because it allows for us to have these open, honest conversations to be able to communicate effectively with the people most adversely affected so that they can get knowledge to make better decisions. Because for the most part, people want to make best decisions, but they just don't know how, right? So then I want to spend the last 10 minutes, and Pastor, I want to make sure that we have time for any questions. And Sylvia, please feel free if you have any questions. But I do want to spend the last 10 minutes just talking about addiction in particular. But I thought it was important to cover the syndemic of COVID-19 and racism and how that plays in exacerbating or making worse existing healthcare disparities. I'm an addiction specialist. I spent so much of my time taking care of people with drug and alcohol problems, but also thinking about how can we eliminate disparities in addiction. For me, I don't see that as aspirational. I see that as something that absolutely can happen when people have access to the best treatment and resources. So all of my work, both clinical and research, is how can we bring treatments that already exist, that are being used mostly by white people, to areas of Black and Latinx folks in a way that's culturally acceptable so that they are not dying from an addiction. Now, what's important to realize is that America, maybe 5 years ago, decided that the opioid crisis was indeed a crisis because white folks were dying. When we know that from the late 60s through the 70s, Black people were disproportionately dying from opioid use.
That's right.
We didn't call it opioids. What did we call it? Heroin.
Heroin.
But you see how when we were dying, it was not a call to crisis at all.
That's right.
It was largely ignored. So the first thing I do in terms of educating Black and Latinx people is that you are a part of this crisis. Just because they didn't call it a crisis back then doesn't mean that it's any less important. And that there are actual medications that can effectively treat people who are dealing with heroin. And one of the most effective medications is a medication called buprenorphine. The trade name is called Suboxone. Unfortunately, because the medication has not been marketed to Black and Latinx people, it has been heavily marketed to white folks. There are so many Black and Latinx people with heroin addiction that don't realize that Suboxone or buprenorphine is a treatment for heroin, and they don't realize that it can help take away cravings and help them lead a better life. So one of the things in Imani that we are going to infuse more and more, but we already talk about it in the trainings that Sylvia goes through, is just alerting people that there is indeed medication that can help people with heroin use.
Wow.
So that's important to know. Another thing that is important to know is that cocaine, powder cocaine and crack cocaine, kills more Black people than all the opioids combined. So at the same time, when we're thinking about a crisis, we have to remember we are in the middle of a cocaine crisis. Where's the media on that?
That's right.
Sylvia can attest to many of the people who are involved in Imani, both Black and Latinx, use cocaine.
Yeah.
Wow.
And so when everybody's focusing on an opioid crisis, we can't forget the cocaine crisis. And again, this is how structural racism rears its ugly head, because this brings into the concept of the racist anti-drug laws, where the Nixon administration actually made it legal for crack cocaine to receive a higher sentence, a longer sentence than powder cocaine. Why? Not because the drug acts differently, because it doesn't, but because Black people are more likely to use crack cocaine. So then think about treatment options. Instead of Black people being led to treatment like white people are being led to treatment now with opioid use, Black people with cocaine use were not treated. Guess where they were sent? To jail.
Jail.
So that is an example of racism at its best that then leads into health consequences, because people with cocaine addiction were treated as if they had a criminal problem as opposed to a medical illness. And there are still people behind bars today with crack cocaine addiction that are not getting the help they need because of racist drug law.
Wow.
So this is important to know. So when people say, oh, that's just a crackhead. No, that is a person of value who had a misstep, who didn't get the treatment that they need, more than likely, and were sent to jail or sometimes even prison. And then it makes it harder to do what? To get a job, to make money, to be able to vote, to participate in making laws and voting for politicians that can help, to be able to pay taxes so that you can have better access to resources. Do you understand how this all contributes to your ability to take care of yourself? And I always say to people, if you don't have any opportunities because of a racist system in which you've been subject to, what are you supposed to do? So that leads to making less than optimal decisions, like stealing or selling things illegally. Not because you don't have any value, not because you don't love yourself, not because you don't love your family, but you are left in a position to operate with very few resources. So again, racism, not race, okay? And this all contributes to addiction, right? So then that's cocaine addiction. Another big addiction in the Black and Latinx community is cannabis or weed. I don't use the term marijuana because marijuana is a racist term that was used by the US government to vilify cannabis use, to make it seem like it was what Mexicans did because they were listless or lazy. And so they said, if you use this drug called marijuana, which to try to demonize the Mexicans, you're bad. So I use the word cannabis because, again, language is power, but I also want people to understand the historical roots of racism that are apparent in all parts of our medical system. So anywho, everybody uses cannabis. Not everybody, but a lot of people use cannabis. What has happened though, is a result of cannabis use, guess who's behind bars? Black and Latinx people. Guess who's making money from the legalization of cannabis? White people.
Mm-hmm.
So now we have a system where people who are being vilified, sent to jail, not receiving any treatment, predominantly Black and Latinx, and we know all the problems that stem from that, versus now white folks being able to sell this drug legally and make money while there are still Black and Latinx people in jail. So one of the things in terms of equity for people with cannabis addiction or people who use cannabis, I always say is it needs to be legalized and decriminalized. Just because you make something legal doesn't mean that it's going to be not criminalized. We see that with alcohol use. Alcohol is legal, but there are still people who serve sentences because of their alcohol use. So I just want people to know it goes hand in hand. You have to make something legal so that people can study it easily, researchers can understand what really are the consequences of cannabis use, but also so that one set of folks can't continue to make money off the back of folks who are still in jail as a result of its use.
That's right.
So if we think about even cannabis addiction, there's disparities because Black and Latinx people don't get help, they get sent to jail, whereas white folks are actually making money. Okay, now let's move on to another big category, and I realize I have about 3 minutes, so I'm gonna stop after this, but well, I didn't tell the truth. I'm gonna talk about 2 more. Alcohol use and tobacco use, because people forget alcohol kills more folks than cocaine and opioids combined. So why do we forget about alcohol? Just because alcohol is legal doesn't mean that it doesn't cause any problems, right?
Okay.
So when we say somebody has an alcohol addiction or any addiction, it's not just that their body becomes physically dependent on that substance, because that can even happen even without an addiction, okay? But we mean that people are unable to function as a result of them continuing to use the substance. They make bad decisions despite the negative consequences as a result of their use. So when we think about people with alcohol addiction, a lot of times what happens is people continue to use despite having problems with their liver, despite having problems with their stomachs, their hearts, their brain. Alcohol affects your heart muscle. It affects your ability to think. People don't understand you can begin to have seizures and die as a result of withdrawing from alcohol.
Yes. Jeez.
It causes disparities in Black and Latinx people because we're less likely to access help when we have an alcohol problem. And that causes more problems because then it affects more organs in your body and it makes it harder for you to live a successful and healthy life if you stop use. Do you understand? Also, many of the programs that were started, let's say AA, Alcoholics Anonymous, were started by 2 white men. Doesn't mean they can't be effective, but I'm saying that it wasn't started through a lens of helping racial and ethnic minority people. So many folks don't feel like that is a comfortable space for them. And it makes sense because it wasn't made with them or for them in the first place. So one of the things that a lot of people don't even realize is that there are actual medications that can help you stop using alcohol. And so many Black and Latinx people don't even know that. And so when we think about treatment, they are not often even given those treatment options. So think about knowledge is power. If you don't even know that there is options available, how can you make a decision to help yourself? So that leads to disparity. And finally, I'm going to come to the last one, which is tobacco use. When I'm thinking about tobacco, I'm thinking about not just cigarettes, but things like blunts. People don't realize when you buy a cigar and you take out the middle and you put weed in it or cannabis in it and you smoke it, it creates a whole nother set of problems. Black men are more likely to use blunts, which increases the risk of cancer. They don't even understand that. We're also thinking about tobacco, chewing tobacco. So there are all ways in which Black people, Black men in particular, have one of the worst outcomes for tobacco use. And again, it's because there is not even a great appreciation for one, the level of risk associated with ongoing use. Everybody just knows cancer, cancer, cancer. Okay, but do you know the statistics related to it? Do you know that menthol cigarettes that tend to be sold in Black communities actually tend to be more addictive than other types of cigarettes that are sold in majority communities? Racism, not race, y'all. And then people don't even understand that blunt use can be detrimental to your system. They think that they're making a better decision to use blunts as opposed to cigarettes, and they don't even understand the risks. And Black men are more likely to use blunts. And when they go to the doctor, this is not accurately communicated to them. So do you understand how all of these things contribute to ongoing disparities in our community? So it is crucial for us to get involved in the conversation. Because if we don't care about ourselves, if we don't provide the knowledge, we can't rely on, and I don't want to be negative, but we clearly see from the history of this country and even what's happening present day, Breonna Taylor's murderer is still not reprimanded. How can we rely on a system that has historically and presently not taken care of us to take care of us? What I'm saying is we have to take care of ourselves. One, provide actual factual data, and then use our talents to communicate it in a way that people can make better decisions, while at the same time advocating for equity in our neighborhood, in our communities, in our medical centers. And Pastor and I intimately know how difficult it is to even infuse the discussion on racism. People don't even want to hear it. And they're the main perpetrators of these oppressive systems. So we have to be involved. We have to make the system accountable, even though it doesn't want to be. And we have to educate our folks who may not have had access to education to understand why they are in the positions that they're in, so that they can do better. But you can't do better if you don't know any better.
That's right.
You can't expect someone who's had a history of trauma and alcohol use disorder and heroin use disorder and tobacco use disorder to make better decisions with themselves, for themselves, if they've never been taught that, guys. There's a reason why there is more addiction in Dixwell and Fairhaven, which are the Black and Latinx communities. There's a reason why there are more people dying from COVID in those communities. It's not happenstance. It's because of historical and present racism. It's because of lack of culturally informed care. It's because of medical mistrust. I'll end with this, because I do think that this is a book that everybody should read. Oh, goodness. The book's name just escaped me. I can see it. I'll come back to it, Pastor. Okay. I'm not old enough to have these memory lapses, but I'll come back to me. Oh, it's by, I can see her and I met the author. It'll come back to me, but it's about all of the medical experiments that have been done on Black and other minority.
Medical apartheid.
Medical apartheid. Thank you, Pastor. Thank you for helping me.
Okay.
And what is the Dorothy? What's her last name? The author.
I forget her last name, but
I'll get it together. But the point of medical apartheid is it delineates in detail all of the really atrocities that have been done in the name of science. And it lays the foundation of why so many people are very and rightly afraid of the existing medical community. So one of the things that the medical community has to do is make amends so that people feel comfortable to even want to engage. So I think it's really important for people to pick up that book and also be able to have discussions around keeping doctors in the medical community accountable so that those things don't happen again, because that can help in terms of eliminating the healthcare disparity. I've talked and talked, Pastor, so I'm gonna stop there.
That was a wealth of knowledge, and you ended on medical apartheid and keeping the medical professionals accountable. One thing that we are proud of in New Haven is that we have a strong partnership with Yale School of Medicine, where I sit on one of their boards as a Yale cultural ambassador. And before any clinical trials or medical research is done in the community, they have to bring it before our board, and that board is made up of African Americans and Hispanics or Latinx, two organizations, AME Zion and Junta, Progressive Action. And so I'm happy that Yale has established that in order to kind of debunk the myths as it relates to those studies that took place that caused us to feel as if, you know, we can't trust medical professionals, like Tuskegee, to name a few, you know. And so now with this new COVID-19 vaccination study, they're going to be needing African Americans to enter into clinical trials. And so that's going to be a difficult conversation for our community. And one thing that you said that stuck with me is you can't blame the addict. You can't blame people for what they say pre-existing conditions.
Amen. Exactly.
But we have to blame a failed system.
Exactly. Yeah.
So the system failed us.
Yeah.
But we as individuals, we have to begin to come to the table like we are today and begin to talk about these things and put programs in place in order to minister to the whole person. So I thank you, Dr. Jordan. I thank you, Sylvia, because hashtag not only does Black Lives Matters, but hashtag Black Health Matters.
Amen. Yeah.
And we have to take that seriously. And so I'm glad that you guys was able to present this, and I'm sure that there's some questions that we possibly can take from the listening audience. And so, so at this time, we'll pause and allow you to collect your questions, and we'll begin to answer them for you.
Perfect.